Hello, welcome to my channel. So today we are going to be talking about Pellagra. So this is case study that can be brought on the Pellagra cases. So this is a patient who is a non-alcoholic who was brought in unconscious. What is the spot diagnosis? These 4 common presentations associated with this. They name 2 core management principles. Okay. So one of the introduction is that Pellagra is clinically manifested by the 4 Ds, which is where we have photosensitive dermatitis or dermatosis, diarrhea, dementia, and death. Don't worry about death because this is the only photosensitivity syndrome where death is included as a cardinal clinical feature. Okay. Then because the full tetrad of symptoms usually not well developed in infants and children. So when you talk about the full tetrad, meaning the 4 Ds, they are not usually necessarily well developed in infants and children. So this vitamin deficiency responds to treatment with nicotinic acid. Okay. And then Pellagra is observed in malnourished individuals and there is complication of isoniazid therapy. Then, however, the diagnosis is often overlooked or delayed, occasionally with life-threatening consequences. Then isoniazid-induced Pellagra may occur despite pyridoxine supplementation. Okay, so what are the risk factors for Pellagra? So most common risk factors, of course, poverty and cons, which is subsisted mainly on maize consumption. Then those people who rarely eat fresh meat. Then HIV infection induces a Pellagra-like state, which is where the plasma tryptophan levels are decreased in patients with an HIV infection. Okay, that's the risk factor. Then also age is also a risk factor. So age, Pellagra is typically a disease that occurs in adults, and it may develop in adolescents and young children if they are exposed to if they are exposed to pellagragenic diet. Then Pellagra rarely occurs in infants. Then historically, dermatitis associated with kwashiorkor was mistaken for infantile Pellagra, but that's kwashiorkor has its own the dermatosis and its own grading as well. Okay, but that's not a Pellagra associated dermatitis. Okay, then in terms of definition, we can say Pellagra can be defined as a systemic disease which results from niacin deficiency, and it is characterized by diarrhea, dermatitis, and dementia, and death, which usually appears in this order. Okay, but remember, conditions never studied books, so it may not necessarily. You can ask someone if they have diarrhea, maybe they might refuse, but you can appreciate the dermatitis. Okay, so it's not always cast in stone. Okay, then the GI symptoms always precede dermatitis, or according to Rye, we can say Pellagra begins in the stomach. That's why I said even if the patient, you ask them if they have diarrhea, they refuse. Maybe they might add in the past, but they can't necessarily maybe appreciate to say, okay, maybe that's what the diarrhea can be associated with the skin lesion. So, but you just have to know that actually diarrhea is Pellagra is a condition that begins in the stomach. Okay, so that's why the diarrhea, the dermatitis, the dementia, and the death appear in that order. Then the skin lesions on the neck are designated as the Casal necklace because it was Casal was one who designated those skin lesions around the neck. Then the reference range for serum nicotinic acid levels is 740 to 790 grams, and this level is decreased in patients with Pellagra. Okay. Then causes, so the etiology is that Pellagra is the late stage of nicotinic of niacin deficiency, and the causes can be classified into primary and secondary. Primary Pellagra results from inadequate nicotinic acid. that is the niacin and or tryptophan intake in the diet. So nicotinic acid can be formed from dietary tryptophan. So that's the primary. Okay, meaning there is no infection. That's the primary. It's just the primary pellagra. So meaning there is no infection causing someone to have pellagra. Okay. Then for secondary pellagra occurs when adequate quantities of niacin are present in the diet, but other diseases or conditions interfere with its absorption and or processing. For example, pellagra has been described after pancreaticoduodenectomy, and of course such conditions include other conditions can include prolonged diarrhea, prolonged or long-term alcoholism, chronic colitis, particularly colitis ulcerosa or ulcerative colitis, okay, idiitis terminalis, cirrhosis of the liver, tuberculosis of the GI, then malignant carcinoid tumor, and Atnapa syndrome. These are conditions that can be considered under secondary causes. Okay. Then in terms of pathophysiology is multifactorial and it involves a lot of systems. Okay, so niacin is essential for adequate cellular function because of its required roles in two similar but distinct coenzymes. That is the nicotinamide adenine dinucleotide, that is NAD, and the nicotinamide adenine dinucleotide phosphate, which is NADP. Then both of these are cofactors that can be recycled by serving as both oxidizing, that's the NAD meaning the NAD and NADP, reducing NADH8 and NADPH agents. Okay. Then during the oxidation of glucose and other intermediate metabolites, a substantial amount of chemical energy is released. NAD and NADH are able to transfer electrons in a process that captures the energy by generating high energy phosphate bonds. Then the synthesized ATP then provides the energy necessary for other reactions of intermediary metabolism that simultaneously regenerate NAD from the reduced NADH. A portion of this cofactor is also converted to NADP slash NADPH, which plays several distinct roles. Now, if there is reduced NAD, the reduced NADPH is used in reactions that detoxify reactive oxygen species. Also, that metabolizes drugs in a cytochrome P450 system, and that support lipid biosynthesis. Okay. Now, because of the large range of organs and tissues impacted by niacin deficiency, the clinical expression of pellagra is diverse, and pellagra is classically defined by the 3Ds, that is the diarrhea, dermatosis, and dementia. So when we say the 4Ds, we include the death, because that's more of the last thing someone can present with. But the 3Ds are the ones which we usually talk about, okay? Because those are the ones someone might present with. So those are the 3Ds, okay? Then almost universally, GI symptoms precede the skin manifestations. Mucosal inflammation and atrophy involves most of the GI tract. Then evidence of glossitis and atrophy of the papilla of the tongue are characteristic findings, along with gastritis and subsequent gastric mucosal atrophy and acute inflammation of the small intestine and colon are also commonly noted. Then skin lesions are usually sharply demarcated and occur in areas more prone to sun exposure or sun-exposed areas, in short. Then histopathological changes include vascular dilatation, proliferation of endothelial lining, perivascular lymphocystic infiltration, and hyperkeratinization and subsequent atrophy of the epidermis. Microscopic changes in the presence of a grossly normal nervous system can be found in the brain, spinal cord, and peripheral nerves. Then findings include central chromatolysis of neurons, patched demyelination, and degeneration of the various affected parts of the nervous system. Okay, so that's the pathophysiology, brief pathophysiology, and you have to know that it's diverse. Okay, but that's the main cofactors that are involved. Okay, then pellagra is often an evolving process which, if untreated, can lead to progressive deterioration and death. Hence the fourth D, like I was saying, but it usually occurs over a period of years. So when talk of the 3 Ds, then you have to know that the 4D comes about after a progressive deterioration. Okay. Then investigations. So investigations, we have laboratory investigations. So the therapeutic response of to niacin in a patient with the typical symptoms and signs of pellagra establishes the diagnosis. Then blood counts. If you do a full blood count, the patient might have anemia. There also be findings of hypoproteinemia. Can also be findings of high levels of serum calcium if you do your electrolytes, and lower levels of serum kalium and phosphorus. The liver function tests and the serum porphyrin levels can help in diagnosing pellagra, but they are not diagnostic. Okay. Then low serum niacin, tryptophan, and NAD levels can reflect niacin deficiency and confirm the diagnosis of pellagra. So these are the diagnostic tests. Then low urinary levels of N-methyl nicotinamide and pyridone suggest niacin deficiency and can support the diagnosis of pellagra. Then the combined excretion of N-methyl nicotinamide and pyridone of less than 1.5 milligrams in 24 hours indicates severe niacin deficiency. So this is the supportive diagnosis investigation, supportive investigations. Okay. Then investigations again, histological, in terms of histological findings. So there is non-specific dermatitic changes that are usually evident, and early changes include a perivascular lymphohistologic infiltrate in the upper epidermis, with mild edema in the papillary dermis, dilatation of capillaries, and later dermofibrosis. Then epidermal changes include early subcorneal blisters, pallor of the upper epidermis, and later hyperkeratosis, parakeratosis, and epidermal atrophy. Okay. Then in carences, the same site, blisters, which is pemphigus perigrossus, and blisters will contain lymphocytes, neutrophils, and histiocytes. Okay, so we are done with the investigation and the histological findings. Then in terms of prevention, if we are talking about primary prevention of pellagra involves an adequate diet, since primarily there is no condition exacerbating the pellagra. Just we can just advise the adequate intake, the adequate diet. Okay. Then food sources of niacin and tryptophan include nutritional yeast, eggs, bran, peanuts, meat, poultry, fish with red meat, cereals, especially fortified cereals, legumes, and seeds. So as a physician or as a medical doctor or a medical practitioner, it's important to know the foods to advise patients you are fine with such ailments. So it's not always that after you treat then you end there. So you have to also do your diet advice. So what are you going to tell them? What foods are you going to advise them? And also don't just advise them to take things you yourself have never even taken, have never even bought, don't even know how much it is. At least have an idea on the patient's socio-economic status, so that if you tell them they are going to buy meat, you know, okay, they are going to afford. If you know, tell them legumes, of course they are going to afford, and what type. Okay, don't give them the impossible task. Okay, then for secondary prevention, the patient should avoid sun exposure during the active phase of the disease. Then patients should also follow a convenient dietary regimen. Then close dietary follow-up after the patient's recovery helps the patient prevent the recurrence of pellagra. Okay. Then in terms of clinical features, we have a lot of clinical features. So in terms of dietary history, the three identifying factors, that is diarrhea, dermatitis, and dementia, and also there will be localization and seasonal appearance, all contribute to the diagnosis. Then early symptoms of pellagra include lassitude, weakness, loss of appetite, mild digestive disturbances, psychiatry or emotional distress, e.g., anxiety, irritability, and depression. Then characteristic and pathognomonic features or skin changes are usually preceded by prodrome symptoms, especially those of the digestive system. So the diarrhea precedes the dermatitis. Then the classic triad is dermatitis, diarrhea, dementia, and not invariably appearing in this order. It's usually more common in this order. Okay, so diarrhea, dermatitis, dementia, diarrhea, dermatitis. So like we said, you don't necessarily follow the order, but so they don't all follow the order of the diarrhea, dermatitis, dementia. Okay, but mostly there is a history of the diarrhea, then the dermatitis. So the diagnosis of pellagra is difficult in the absence of cutaneous findings, and skin lesions or pellagrodemas, as they are termed, are painful on site of erythema. Then burning sensations, headache, and weakness might also occur. Then itching is never present, so there's no itching in the clinical features. Okay, so we can talk of the clinical features. Maybe we just exhaust them on the hands, feet, neck. So we try to know also how they look. Okay, so of course there will be redness and superficial scarring which appear on the areas exposed to sunlight, heat, friction, and pressure. So in terms of the ants, the backs of the ants are the most common sites for the lesions in 77 to 97% of the cases, with a situation of the radial border of the dorsal aspect. Lesions may extend up the arm in the groove or gauntlet form of pellagra. Then the epidermis of the fingers thicken and the articular folds disappear, and there will be painful fissures which may develop on the palms and digits. Okay. Then in terms of the face, so dermatitis will also tend to follow the distribution of the trigeminal nerve, and the skin is invariably pigmented. A symmetrical butterfly eruption is frequently observed, which also this appearance, which is also common or similar to that of the lupus erythematosus eruption. Okay, then a characteristic well-marginated eruption often appears on the front of the neck, that is the Casal's necklace, compared with the scales elsewhere. Scales on the face are thicker and larger and frequently becomes pustular. Then the symmetry and clear line of the demarcation from an affected skin are especially striking. So the lesions tend to spread from the sides to the rest of the nose, forehead, cheeks, chin, lips, and more rarely eyelids and ears. Then on the forehead, a narrow border of an affected skin always appear between the erythema and the ear. The facial lesions never appear independent of lesions on the hands and elsewhere. Okay, so recap on what we are talking about is these two pictures, as you can see on the face, as well as a reminder on the arms or on the hands, is what we are talking about. Okay, this is the features on the face. Okay, then the features on the neck. So on the neck, the Casal necklace extends as fairly broad band or collar around the entire neck, which is the cervical dermatoma with C3 and C4 innervation. Then if the band is incomplete, the symmetry of the regions is still striking, and the upper border extends anteriorly somewhat below the hairline to the larynx. Then the lower border begins under the vertebral prominence and extends to the edge of the manubrium steni, which is the appendix fasciculae. Okay. Then in many instances, the necklace has an anterior continuation or broad cravat extending from the manubrium over the sternum to the level of the nipples and ending in a point or square on the back as well, and the border may reach the level of the scapula. Then affected men, women, and children have the necklace. It is always accompanied by the characteristic dermatosis elsewhere. Okay, so this is the Casal's necklace, as you can see, especially more typical ear as well as more typical ear. Okay, and this area, as you can see, the skin is different from the areas from the sun exposed areas. Okay, I hope you can appreciate that. Okay, so let me just take out these pointers so that you'll be able to appreciate them. Okay, then in terms of the feet, lesions usually do not extend proximal to the malleoli, which are included and may be covered with hyperkeratotic erythema. Then the heels remain free of lesions. Distally, the eruptions ends at the toes or on the backs of the great toes. Then the front and back of the leg may be involved to form a boot. And on the palms and soles, skin may be yellowish, dry, rough, and scary. Then in children, the palms and soles are frequently erythematous and rough. Okay, then other sides, the shoulders, elbows, arms, knees are occasionally affected. Then asymmetric lesions may appear at sites of odd injury or stasis. The nails, the changes are not pathognomonic. Nails are usually soft, crumbly, and dull. Occasionally transversal lines are present. Then the eyes, there can be keratoconjunctivitis and keratomalacia which may occur. Or it's more the lesions are more common in areas which are sun exposed. Okay, that's the thing you have to understand. So these are the lesions on the feet. Okay, as you can see, and also some nail changes. Okay, that's pellagra. Okay, then on the mucosal surface of the GI tract, you have to know that in 1/3 of the patients, the lips, the tongue, and the mucosal membranes, they are involved. Highly seasoned or acidic foods can cause mucous membrane inflammation and aggravate tongue and mouth soreness. Then there will be a typical changes of the tongue and mucous membranes, which include inflammation and edema of the tongue, apex, and edges. Then the tongue is hypertrophic with pseudomembranous fuzz, erosions, and ulcers. Later, the tongue becomes atrophic. Then other clinical findings include cheirosis, angular stomatitis, and thrush, and the bleeding from the gingiva then occurs without hemorrhages. Then you have to know that the hemorrhages occur in scurvy. Okay, then the lips are inflamed, rough, achy, and shiny. Okay, then in terms of the GI tract, the GI tract disturbances can cause poor appetite, nausea, vomiting, then epigastric discomfort, abdominal pains, and increased salivation, diarrhea, gastritis, low levels of duodenal enzymes, and acrolelia occurs in almost 50% of the patients. Then atrophic changes of the gastric mucosa are demonstrated on radiographs. Glossitis causes soreness of the mouth and dysphagia. Anorexia and malabsorptive diarrhea lead to a state of malnutrition and cachexia. So the diarrhea results from the diffuse involvement of the mucosal surface of the GI tract. Typically, stools are watery but occasionally They can be bloody and mucoid. Okay, so those are the clinical features. Then lastly, we have the neuropsychiatric manifestations. So in mild instances, mental disturbances may be unnoticed, and patients may be slightly depressed or apathetic. Then the neuropsychiatric manifestations include headache, irritability, poor concentration, anxiety, delusions, hallucinations, stupor, apathy, psychomotor unrest, photophobia, tremors, ataxia, spastic paralysis, fatigue, and depression as well. Okay, so the fatigue and insomnia progress to encephalopathy, characterized by confusion, memory loss, psychosis, occasionally frank disorientation, restlessness, and severe symptoms of the central nervous system occurs. Then peripheral neuritis and myelitis are occasionally encountered. Then as the disease advances, the patient becomes disoriented, confused, delirious. Eventually, the patient becomes stuporous and comatose, and they die. That's the fourth D. Then pellagra encephalopathy should be suspected in patients with alcohol intake, presenting with a rapidly progressive dementia combined with paraparesis or tetraparesis. The neuropathy, visual disturbance, myoclonus, and may also be considered as a differential diagnosis of sporadic uh, C, uh, CJ disease, so the Creutzfeldt-Jakob disease. Okay, then in terms of differential diagnosis, we can have drug eruptions, drug-induced lupus erythematosus, drug-induced pemphigus Hartnup disease, pediatric atopic dermatitis, pemphigus vulgaris, polymorphous light eruptions, porphyria cutaneous candida, seborrheic dermatitis, subacute cutaneous lupus erythematosus. Then in terms of management, so management we have the oral therapy oral therapy with nicotinamide or niacin, which is usually effective and in reversing the clinical manifestations of pellagra, because patients are often malnourished and have other vitamin deficiencies. Then provisions for a high protein diet and the administration of B complex vitamins are needed for complete recovery. Then patients with acute pellagra require bed rest during the initial phase of treatment. Patients with severe glossitis require a liquid or a soft solid diet to overcome dysphagia, and ensure that the patient has a balanced diet that is rich in protein and niacin. Then the topical treatment of skin lesions with topical emollients may reduce discomfort. Then in terms of diet, also to prevent and treat pellagra, describe a protein-rich diet with adequate calories. So that's why I was talking about you knowing what kind of food contain the B vitamins. Okay, so the addition of meats, milk, peanuts, leaf green vegetables, avocado, or enriched grains, brewers, dry yeast can enhance niacin intake. Then in patients with oral dysphagia secondary to glossitis, a liquid or a semi-solid diet may be required. Then the long-term inclusion of milk, meat, eggs in the diet ensures the dietary adequacy of the protein is essential for recovery. Okay, then in terms of complications, so we can have dermatitis of pellagra, which can be distressing and disfiguring. We can have denudation of the vesiculated and blistered skin lesions, which can potentially become infected secondarily. Then we can have severe glossitis, which causes dysphagia, and GI tract involvement, which may lead to a malabsorptive state. Then depression, anxiety, delusions, hallucinations, and coma are the neuropsychiatric complications observed in patients with pellagra. Then the malnourished state associated with pellagra results in death if untreated. Okay, then for the prognosis, if pellagra is diagnosed and treated appropriately, the prognosis is recovered is excellent. Then the dermatitis tend to be pruritic, often with a painful burning sensation during the acute phase. Although patients may be asymptomatic, the skin eventually becomes hypopigmented and some patients consider this disfiguring. Then the systemic effect of the disease include malaise, apathy, weakness and lassitude. GI tract involvement lead to malabsorptive state and the subsequent failure to thrive, especially if in pediatrics, though it's uncommon for them to develop the condition. The neurologic manifestations include anxiety, depression, delusions, hallucinations, and stupor. That's the prognosis, how it can develop. Okay, then that's the end of the lecture. Then we started with this case study. So we said the patient is a non-alcoholic who was brought in unconscious. Spot diagnosis, so you can appreciate the Casal's necklace. So of course you've known the spot diagnosis, pellagra, 4 presentations associated with this. So you can either use the 4Ds, or you can still continue with adding the other symptoms, the neuropsychiatry manifestations and others. It's okay. Okay, since at least if you are, they give you 8, you can mention them. You have to know that the 4Ds are not the only features. Okay, as we have talked about a lot of features. Then name the 2 core management principles. Of course, the therapy for the nursing, the prevention. Okay, then of course if there is any underlying pathology, also look at the underlying pathology. So in short, the pre-primary and the secondary also should be looked at. Okay, so that's the end of the tutorial. Thank you for watching. If you haven't subscribed, please subscribe and hit the bell notification. And thanks for watching once again. Check out other videos as well on the channel, and see you on the next tutorial.